I'm going to talk today about practical patient safety. Patient safety outside of the doctor's realm tends to be thought of in terms of things like avoiding falls or catheter-associated urinary tract infections or deep vein thrombosis in hospital. These are important, but I think that doctors tend to approach the subject from a different angle. So I'm going to define the work of my inpatient team. The work of my inpatient team is to swiftly, effectively and safely treat acutely ill medical patients and get them ready as early as possible to safely resume living outside hospital. For a small proportion of patients, our work is to anticipate end of life and to help to ensure a calm death. We also work to train the next generation of healthcare workers to better our performance. So I can summarise this as right diagnosis, right treatment, at the right time, in the right place, with the right to no avoidable harm, and that's where the patient safety movement usually comes in, and better next time. So our work is to take our patient and help them across the tightrope of hospital admission, passing on their care from one team member to another and hoping that they're not going to fall. Of course, if they fall, we want to try and rescue them and keep them safe, but if their falling is dying, we want them to experience a calm end of life. So if I make the wrong diagnosis, the patient is not safe. If we deliver the wrong treatment, the patient is not safe. If we deliver the treatment too late, the patient is not safe. If we deliver the treatment on the wrong ward, with the wrong care team, without the expertise in that specialist condition, that's not safe for the patient. If we harm the patient through omissions or errors that arise as a consequence of our interventions, that's not safe for the patient. And if we fail to train the next generation of doctors and nurses and healthcare workers, the next generation of patients will not be safe. Doctors rarely describe the clinical care cycle. This is the way that we work. At the top of the diagram there, where it says diagnoses and comorbidities, this is usually what's happening in the accident and emergency department or on the acute assessment units. In the context of what's known about the patient already, the comorbidities, we try to work out the current diagnosis and often express this as working diagnosis or impression. Some people believe that the diagnosis is written onto the patient's forehead as they come into the room, but this is not the case. We have an idea, an impression, a working diagnosis. We institute some rational treatment plans, see how the patient progresses with that, monitor the patient, review their progress, and then refine our diagnoses and comorbidities. Recently I had a patient and the admission diagnosis was extremely unwell with high fevers. We weren't certain where this was coming from, but we treated her with broad spectrum antibiotics. Within 3 or 4 days of admission, that had been moved from that working, pragmatic diagnosis to an abscess in her liver. When the patients arrive extremely unwell in the resuscitation department in accident and emergency, the treatments may be instituted before there's very much in the way of diagnosis. And we keep going round this cycle time and again, usually on daily ward round reviews, until the patient is either better or well enough at least to be able to leave hospital, or has deteriorated and died. When clinicians look at this, it makes sense to them. It's interesting if you're a manager who's been interested in quality, continuous quality improvement, that you'll recognise this as a plan, do, study, act cycle, which should go around time and time again with continuous quality improvement. And it struck me that it's interesting that doctors very rapidly move into this cycle with a patient and are happy dealing with uncertainty, and will go round the cycle until the patient has improved and is ready to leave hospital. Take the same doctor and ask them to try to change a clinical care pathway or a clinical process, and they're all at sea and very much doubt the validity of their interventions and don't go about things in the same way that they do with a patient. Now, without picking up paper or pen or your mobile phone to take a picture, I want you to remember these 10 items, and I'll help you by reading them out. Coffee, smorgasbord, sword, amylase, CT results, longboats, and electronic record. Now, Benjamin Franklin, who helped to set up the United States of America and the Declaration of Independence, said that failing to prepare is preparing to fail. And by corollary, preparing is preparing for success. So how do we prepare for success in diagnosis? I think there are definitely things we can do to help to prepare and to prepare our process and to keep the patient safe. If we don't do these things, I think it's a bit like the flautist here heading off into the 1812 overture without having read the score. He'd be all at sea and things would go badly wrong. To illustrate this, here's a tale of two patients. The patient with the red, hot, swollen knee was a man in his mid-70s who, a week before, had had some treatment at a local cancer centre for a bladder cancer. He arrived with high fever and having rigors and a swollen knee, and the assumption was that something had happened as a consequence of his treatment the week before, which had resulted in sepsis and probably a septic arthritis. We didn't have any details from the local cancer centre, although we knew he had been referred there from our own hospital 6 months earlier for a possible treatment with something called hot mitomycin. He was treated overnight with 3 antibiotics, and the following morning my registrar reviewed him and we could find no further information about the patient, and the patient himself said the general practitioner also knew nothing about his condition. We decided to continue with the antibiotics in case he had sepsis, try and get an orthopaedic surgeon to come to review his knee, and to try to phone the cancer centre and get some information. It proved impossible to get any information from the cancer centre on that Friday, and we kept trying all the way through the next week until the Thursday, a week after his admission, when we finally managed to find some information from the cancer centre. At the cancer centre they'd instilled not hot mitomycin but attenuated BCG, and when we went back to tell the patient, he said, "Oh, I remember I had that treatment once before and I got a similar sort of reaction." We discontinued the triple antibiotics. He was fortunate he didn't get C. diff or MRSA or miscalculation of his dose of gentamicin causing deafness. He had a whole week of treatment for the wrong diagnosis because we didn't know the known facts that already existed within the National Health Service but were impenetrable to us. We made a misdiagnosis only because we didn't have the facts that we should have done. This is very common throughout the NHS, that we can't discover the information we need to have that is already there somewhere. Second patient was admitted with cardiac failure caused by severe aortic stenosis, and the morning after his admission the nurses reported that when he drank his water before he went to bed, water came out of his nose. I thought maybe he had an enlarged left atrium blocking his esophagus, and interviewed him on the following morning and examined him, and he was perfectly able to drink water without it coming out of his nose, so I put the matter to one side. The following morning we were told the same story, and once again the patient could drink water without it coming out of his nose. We were having difficulty understanding why he hadn't had his aortic valve replaced, and the junior doctor went through the notes and discovered something we didn't know, which was that a few weeks before the patient had been to the ophthalmology outpatient department with double vision. They'd requested the acetylcholine receptor antibody test for myasthenia gravis. The result had been processed and was positive, but had not yet been seen by the ophthalmologist or reported to the GP or to the patient. The diagnosis was therefore aortic stenosis with cardiac failure and coincident myasthenia gravis. Again, we made a delayed diagnosis simply because we didn't know pre-existing facts. We were always taught, go through the notes, but these days, with the notes being half paper and half electronic, it can be very difficult to do this, and with the electronic notes it can be difficult to navigate one's way through and find out what has and what hasn't been done. Now I'll tell you a good story of the acute abdomen, which was diagnosed by our colleague Ella, who's running this conference. A man from overseas with his family was travelling around Scotland and went to one of the best seafood restaurants in Oban early in the evening, and with the first mouthful of food developed severe abdominal pain, had to rush to the bathroom where he vomited, came back from the bathroom and collapsed on the floor in the restaurant. The restaurant owner called 999 and is very swiftly brought to our accident and emergency department where I was on call. I'm a physician and I went and examined him. He was in extreme pain, he was grey, but his vital signs were stable at that stage. We set up some intravenous fluids, gave him some morphine, and examined his abdomen to see if there's any evidence of a perforation, obstruction, hernia, aortic dissection, or perhaps an acutely collapsed thoracic or lumbar vertebra. And I couldn't make a diagnosis at this stage beyond the fact that he's extremely ill, and it looked as probably something badly wrong in his abdomen. I phoned Ella whilst I was looking up causes of food poisoning that might cause severe pain, or diseases from his country of origin which might present in this way. Ella turned her car around, drove back to the hospital, and I think spent about 8 minutes with the patient and came back and said, I'm taking him directly to theatre. I asked if she didn't want a CT scan of the abdomen first, but she was insistent she went to theatre. I think by the time we got to theatre we knew that his erect chest x-ray didn't show air under the diaphragm and that his amylase was normal. When Ella opened up the abdomen, rosé wine-coloured fluid came out of the abdomen in quite copious amounts, followed by us being able to see nearly necrotic small bowel. As Ella explored inside, found that the small bowel had slipped through a hole in the omentum and then had become strangulated and was very dusky and on the edge of necrosis. She managed to extract all the bowel back through the hole in the omentum, sew the hole in the omentum up, and thought that the bowel was beginning to look sufficiently healthy that he didn't need a resection. If he had needed a resection, he would have probably died on the table because he was so unwell. He was then transferred, ventilated by helicopter to Glasgow, and 2 days later had to have a further laparotomy where most of his small bowel was removed, and he was left with 70 centimetres of small bowel. Despite such a small, short loop of bowel, he was able to eat and has been able to return to his home country. This case illustrates that the diagnosis doesn't need to be anything more than, I believe this man is extremely unwell and needs a surgeon, and the surgeon's diagnosis doesn't need to be any more than, I'm sure there's some intra-abdominal catastrophe and I need to get in there and try and put it right now. And then the diagnosis became clear. I think in this case, had we waited for the CT scan to warm up, to get the radiographers in, to get the remote report from a radiologist, the gentleman would probably have died that day. So we can make very good diagnoses without being too specific, moving through from the working diagnosis to the final diagnosis, and a lot of the management of this patient relied on Ella's considerable expertise in the practice of rural medicine. Now, there's a big science of the analysis of diagnostic error. I think a lot of this science is flawed. It's based on retrospective analysis of the notes, or the charts as they call them in North America, and the results, and is very open to retrospective bias. If observers are told that an outcome of a case is satisfactory, they don't find very many errors in the case. If they're told that the outcome of a case is death, they'll find double the number of errors just because they know that the outcome was bad. So the doctors looking at the notes already know that there's been a misdiagnosis. They know what the misdiagnosis is, and they're going to find more errors just because they're looking retrospectively. We also don't know the denominator. So we don't know what the rate of misdiagnosis is because we don't know what the rate of correct diagnosis is. Is the rate of misdiagnosis 50%, 5%, 1%, or 0.5%? We don't really know. We don't know whether it's increasing or decreasing, and this is because we haven't done prospective studies of misdiagnosis. I also suspect that those who are working in misdiagnosis wouldn't be able to answer the question as to which diagnosis are they using as the correct diagnosis. Is it the diagnosis as the reason for admission, the diagnosis as at 24 hours, as I believe is used in Dr. Foster's analysis? Is it the working diagnosis? Is it the post-mortem diagnosis? Is it the diagnosis on the discharge summary? And which diagnosis do you choose? a patient who came in with an anterior myocardial infarction and then developed cardiac failure, a left ventricular aneurysm and had a stroke, which of those diagnoses are we going to use as the diagnosis for the admission or for the discharge? So another problem is that a patient who had, for example, cardiac failure, chronic obstructive pulmonary disease and pneumonia, the leading diagnosis would be cardiac failure if he happened to end up on a cardiac ward, it would be COPD if he ended up on the respiratory ward, and might be delirium and pneumonia if he ended up under the care of a geriatrician. So we're not quite sure, I think, which diagnosis is correct. But I think we'd all recognise that misdiagnosis happens, and it can be harmful or lethal, but whether we're actually doing very well or very poorly is a little bit difficult to work out. If we look at the charts and the papers and the fluid input, the prescription charts, these other things, and try to work out whether misdiagnosis happened, we're looking in the wrong place. Misdiagnosis is a bit like going through a maze. It's actually more complicated than this. I think it's a three-dimensional maze that we're going through. And if we had a system for looking at a doctor going into a maze and finding her way around inside the maze, we might be able to study where she turned left, where she turned right, but we wouldn't know what was going on inside her mind when she turned left or right or reversed back round and tried to find a different way through. So somehow we need to be able to get into the mind of the doctor who's involved in the diagnosis and know what's going on. The notes are not really very helpful, I think, in identifying what's been going on in the mind. The notes are much more the answer than the working out, and may not even be a very good record of the answer. And this is where diagnosis happens. It's like doing mental maths. If you look here, the two consultations, the doctors and the patients, eye to eye, they're intently listening and talking with each other. The doctor's mind is full of thoughts about what the diagnosis, what the treatment is, and what on earth's going on. It's a mental activity, a high-level mental activity. So it's a bit like trying to do mental maths, where what's important is the answer, but we can't see the working out. So this sum here, 2 squared times 3 cubed times 4 to the power 4, if you were to try and work that out in your head, and then I turn on the Hoover, and the patient, then somebody's mobile phone rings, and somebody asks if you can write up a prescription and reminds you that the 4-hour target is under threat, it would be very difficult for you to do that mental maths. Clinical consultation is attentive listening and diagnostic reasoning at the same time, two very high-level activities. As soon as we ask the doctor to write in the notes, then they're doing 3 high-level activities. And then if we're asking them to manipulate a computer so it can find the chest x-ray or look at the potassium result, the brain is overloaded. So this is why the doctors were not writing in the notes. There wasn't enough space left in their brain to do another high-level activity. It's the same as why you turn off the radio when you're reversing. Reversing requires high-level mental activity. And if you're distracted by the radio or by the discussion with other people in the car, it's very easy to make a mistake and to end up crashing or damaging your car. This is because of the limited ability of the human brain. So if you liken our brain to a computer with 4 megabytes of RAM, we can't expand the RAM to 8 megabytes. And if we have too many tabs open, the brain stops working and drops off some activities. What's left is our consciousness, and we're unaware of the things that we can't see outside our area of consciousness. As I said, attentive listening and clinical reasoning by themselves fill the RAM. We don't have 2 brains, and we can't slip in another 4 megabytes of RAM. Unfortunately, we're not like Steve Martin, the man with 2 brains. So I don't think those who study misdiagnosis and ourselves as doctors really express very clearly what's going on inside the doctor's brain during the maze of diagnosis. Now I want you now to write down those 10 items from slide 1. Now the first thing I know is that you're going to say there were only 7 items. Well, that illustrates those 2 cases of misdiagnosis where you couldn't get the answer correct because nobody had supplied you with the information in the first place. There may be 1 or 2 people in the audience who can remember those 7 items, but you're unusual. And the point of this is that we often discuss a patient in a room to go through the diagnosis and the test results and come up with a list of 7 or 8 diagnoses and problems that the patient has, and then there may be a 15-minute gap until we get to see the patient, by which time we will have forgotten some of those things. So we're going to get things wrong just because of the limitations of human memory and our RAM. Those are the 10 things: coffee, smorgasbord, sword, amylase, CT results, longboats, and electronic record. This is what sort of thing goes on inside my head. Imagine we've prepared for a ward round review and the junior doctors have presented to me the case of a lady who seems to have pneumonia and diabetes with very high glucose levels. If I'm the consulter, this is the sort of stuff going on in my brain whilst I consult with the patient. Wow, she looks very thin and has clubbed, tar-stained fingers. I wonder if she has a lung cancer as well. Have I introduced myself clearly and got a good rapport going? This could turn into a tricky consultation. Oh, she's mentioned a headache. Maybe she's got metastases to the brain or temporal arteritis. Have we measured the ESR? And did we even look at the chest x-ray? No. She says she hasn't been outdoors for 6 months, so maybe she could be vitamin D deficient. Will we measure the vitamin D level or just prescribe some? Maybe she's already on vitamin D. She was on a long list of meds. Why is the student looking bored? I'll ask him to look up the meds list, and the F2 can look for an ESR. Now, should I go on to the high glucose problem or the pneumonia next? Oh, her husband's arrived and he looks angry. Where's the nurse gone to? I need her to hear the whole conversation so she can calm the patient and her husband down after I leave if this all turns out difficult. And I must remember the medical director said we're doing poorly on VTE prophylaxis and dementia forms and looking for pressure risks, and the 4-hour target is going badly. Could I discharge the lady and do all her investigations as an outpatient? And damn, there goes Henry the Hoover, and the F2 is left to answer her bleep, and PAX has gone down, so we can't review the chest x-ray. Now, how many years have you smoked for? Well, that's what it's like for me, however calm I look from the outside. This doesn't leave any residual power. This doesn't leave any residual computing power for my brain to think, could this be an overactive thyroid, or badly fitting false teeth, or depression, or only drinking alcohol and no food? Sorry about that. The computer started jumping around with its voice dictation. So we need to make sober decisions in that context, and you expect us to make sober decisions as sober as a judge. But look at this. This is an interesting study about judges and their sober decision making. The easy decision, if you're a parole judge, is to keep somebody in prison. The difficult decision is to send them out. And these judges made the difficult decision to give people parole if it was just after breakfast, just after the mid-morning break, or just after lunch. And after that, their decision-making went off. And the judges just didn't know this at all. They were unaware of it altogether. So important decision-making could be degraded just by not eating breakfast, not taking a mid-morning break, and not having lunch. Now, I know many junior doctors go through a 13-hour shift without having had breakfast. They don't have time for lunch. They don't have time for a break. And many consultants as well will go through 4 or 5 hours of an outpatient session without any break. Our decision-making probably degrades like this. Other things can overfill our RAM, so disturbances like the Hoover, people's mobile phones, people interrupting. Interrupting is a very potent way of breaking down high-level mental activity. We either cover again the same item, or more often we miss a bit out and we miss a crucial bit, for example, of the history. Or just simply don't think of anything like the thyrotoxicosis because our brain's just too full already. So it looks as if our brains probably last about 2 hours. We can't just plug into the mains like with a laptop. We need to get our brains refreshed. Refreshment breaks, I think, are called refreshment breaks because they refresh mind, body and soul. A break is sitting down or walking around, having a coffee. Don't have the mobile phone on, don't have emails, don't make a task list for what to do next, don't answer the bleep. It's a proper break. And many doctors around the world are working long hours without any proper breaks, so they're likely to be making misdiagnoses. A zealous doctor can be a great danger. The doctor who says, I can't go for my break, there's 4 more patients in A&E, may serve those patients very badly by not going for a break. So lots of doctors now feel that healthcare managers aren't interested in their health, in the doctor's health, but they should at least be interested in the doctor's brain, because this is where diagnosis goes on. So how can we look after the doctor's brain? One thing I do is pre-prepare for the ward round, so prepare my brain for knowing how much is going to be going on. So how many patients have we had come in, how many critically ill, how many might need early attention, how many might be going home, checking out with the junior doctors about how busy they were, setting a plan for what will happen if things go wrong during the ward round. If there's a cardiac arrest, will the registrar leave? That, I think, primes the brain for the round. I spend a lot of time both when I'm on take, admitting acute patients, or preparing for outpatients, finding out the background information, the background circumstances for the patient before I go to see them. These sort of diagnostic lists and medication lists are not the answer. They're the information that other professionals have come up with and which I must respect, but at the same time be sceptical about. I think this sort of pre-preparation, again, takes stuff out of the RAM, puts it onto paper, it's in front of me. If I can see that on my tablet PC on the ward round, or on the PC in the clinic room with the exact same copy for the patient to see, this empties the RAM so we can get on with the task. Another thing I worry about is whether we miss something important, these safety aspects. Have we taken out the catheter? Have we taken out the cannula? Has the patient got pressure area risk? Is all our good work going to be undone because we haven't reviewed the drugs chart, left the patient on something which is toxic, or not prescribed something we should have done, left them on antibiotics too long? A whole lot of stuff that needs to be done, something around 25 decisions per patient per round. If I give that list to a medical student and tell them to check that we do everything, that's another weight off my mind. Similarly, if I say to the registrar, you look after the medication list, you listen to the diagnoses, you listen to the patient's progress, you deal with the issues that are coming up, keep me informed what's happening, another big bit comes out of my RAM. Doing a reverse roll round where I ask the junior doctors to do the consultation whilst I stand or write the notes, observe what's going on, again, frees my mind for a lot of observation work, development of the team, feedback to the juniors, teaching, training, but also it frees my mind to think, and I can think of several patients where I've made diagnoses during reverse roll ward rounds that I would not have made otherwise because my mind is free to think. So all of this is exteriorizing tasks from our brain RAM, emptying the brain so it can do what it needs to do, listen and think. We can eradicate distractions. One of my previous chief executives moved the cleaning schedule from the morning to the afternoon so that Henry the Hoover wasn't invading all the consultations and it was quieter to think. Valdemar Erling over in Sweden has developed a ward round room that patients can come to. The multidisciplinary team can be there. The patient is sitting up instead of with us towering over her. And those consultations immediately felt different to me and something very different. Quiet room, all the computers information around in the background, need less computers because the consultation room don't need a computer at every bedside. Much better consultation, I think, probably empties the RAM again and allows better communication, better thinking, better diagnosis. Another way to improve diagnosis is to make sure we know the person first before we launch into the history and examination. These people, this man hasn't introduced himself properly to this woman. You can see the distrust and the closed body language. They're not going to speak very much to other. A lot of the history, a lot of the diagnosis comes from what the patient tells us, and we listen to it carefully. So I try to get the patient talking by asking them simple questions. What's your age? What is or was your occupation? What are your current interests outside work? And what do you enjoy these days? The patient knows I'm interested in them as a person, and will then open up much more in the history and may make the diagnosis far easier to make. So if you want to improve your diagnosis, start with this and don't put it as page 4 of your history taking. Other things, if we're struggling with diagnosis, I've developed a bookmark for better care, which gives a guidance to walking through a case where you're having difficulties. Unfortunately, we're not very good at stopping and realising the cases we need to go through in greater detail. Somehow, although we know the case is difficult and complex and we're struggling with the diagnosis, we still don't stop and work through it properly and don't turn enough to ask for a friend. I'm very pleased to ask Ella to see the patient with the strangulated bowel. This is a diagnostic aid called Isabel Healthcare, where you just put in the information about the case, and it will come up with conditions that you mustn't miss. So this is a case from the Bauer-Garber incident, a child of 5 years old in Western Europe with fever, diarrhea and acute kidney injury. As you can see, sepsis and shock does appear there, but not pneumonia caused by group A streptococcus. And not surprisingly, because group A streptococcus doesn't often cause pneumonia. Need to have 3 feasible diagnoses. Another thing to do is to think about getting everybody to do 3 feasible diagnoses, differential diagnoses on every case we see. We tend to think this is an obvious case of appendicitis, don't need to think of a differential diagnosis. But even if it is an obvious case, perhaps we should also think at the same time, what's the most dangerous and what's the most rare but feasible? So if it's chest pain with vomiting, most likely it would be acute myocardial infarction. Most dangerous, dissection of the thoracic aorta without an aneurysm, and rare but feasible could be Boerhaave syndrome, vomiting against a closed esophagus, rupture of the esophagus into the pleural cavity. Now if we do that for every case, however certain we are, that would keep our minds agile like a weightlifter keeps his muscles agile, so that when we did come to the difficult case, even if we didn't recognise it was difficult, we'd at least be coming up with 3 differential diagnoses. In Sweden, when I went to visit Valdemar, they had Fika. Fika is coffee and cakes. The morning handover was full of very nice coffee and cakes, very pleasant surroundings, very good handover from the juniors. Then we went to see some patients, 4 or 5 patients, in the ward round room, and then we stopped for Fika with the nurses on the ward because it was a Friday. Then we saw some more patients, then we stopped for lunch. So we were protecting ourselves like a good parole judge would by having breakfast, mid-morning break and lunch. So if our employers want our brains to be razor sharp for diagnosis and incisive action, they better make sure that we get proper breaks. And that would help us to get it correct first time. I say correct first time because, of course, if we're talking about correct rather than left and right, we should say correct rather than right, which will cause confusion. And this is just reminding us that the people investigating have hindsight bias, and they can see what happened. They can't see all the variability and the possibilities that were on this side. They know what happened afterwards, and because they know it went wrong, they pick out more mistakes than if they were looking at it blind. So 70% of diagnosis happens in the consultation. We need to take care of our brains. I have an idea that we could give the hospital executive team a set of Tamagotchis called Doctor's Brain. And these so after 2.5 hours and the doctor hasn't had a stop to go for a pee and a cup of coffee, the little Tamagotchi would beep and say, the doctor is about to organise a PET scan which will cost £75,000 and it's unnecessary. You perhaps better go and give the doctor a cup of coffee and ask them to reconsider the decision. Or the doctor hasn't had a rest now for 9 hours during a busy night, is about to make an error on a dose of medication which will cost the hospital £5 million in compensation 5 years down the line. Perhaps you better send somebody to relieve that doctor for half an hour so they can get 15 minutes power nap before they resume their work. What we need is genius ways to keep our minds razor sharp. So my theme has really been, like in Men in Black, empty your brain so you can think better. Exteriorise as much work as you can. This will leave our minds clear for attentive listening and diagnostic thinking. Thank you.